we can start now, or we should wait a few minutes because usually people takes some time to join the meeting.
Salvatore, you decide.
I think we can start. We can start now.
Yeah.
So, okay. Good afternoon to everyone. This is a data parasite section from the Italian Society of Parasitology with the focus on control and elimination of STH, soil-transmitted helminthiasis. And today we have the young group of the Italian network on entities that will coordinate and manage these sections. And I'm happy that you will do that. And please, Salvatore, I think you are in charge of managing this section. The floor is yours.
Yeah, thank you very much, Adriano, for your kind introduction. So many thanks to SOIPA for hosting us within this data parasite webinar, and also to all participants joining us today. So it's a pleasure also to be here on behalf of the Young Italian Network on NTD group for this session. The session titled From Control to Elimination, Advancing Strategies Against STH. This is a great opportunity to discuss a group of infections that still represent a major public health challenge in many endemic settings, and to reflect on the steps needed to move from control toward elimination. So before we begin, I would just like to quickly check with our speakers. Benedetta, can you hear us well?
Yes, I can hear you. Can you hear me?
Yeah, good. Michele, can you hear us?
Yes, I can hear very well. Can you hear me?
Thank you. And also Bosco, can you hear us?
Yes, I can hear you well. Thank you.
Perfect. Thank you. So just a brief note on the format of today's session. Each speaker will have 15 minutes for their presentation, followed by 5 minutes for question and answers. If we still have some time at the end of the whole presentation, we will also be happy to open the floor for some additional discussion. So let us start with our first speaker, Dr. Benedetta Rossi. Benedetta is a medical doctor specializing in infection disease and currently works in the Department of Tropical Medicine at Brescia General Hospital. Her clinical and research activities are mainly focused on tuberculosis and neglected tropical disease. She is currently completing a PhD on neglected and poverty-related disease from One Health perspective, in collaboration with the University of Brescia and the University of Cameroon. As part of her research, she spent several months in Mozambique conducting field research on STH infections and schistosomiasis. They also add that she is a member of the Young Italian Network of Entities, and today she will present preliminary results of a prevalence study on soil-transmitted infections in a rural area of Inhambane province, Mozambique. So Benedetta, the floor is yours.
Thank you, Salvatore, and thank you all. I will share my presentation. Okay. Just a second.
I think she's freezed now.
Benedetta, can you hear us?
I would say nice talk.
I think she goes out.
I don't know what happened. I'll try again. Sorry.
You are connected twice.
I don't know what is happening because it said that I. Can you see my screen now?
No.
Not yet.
Do we have a copy of the presentation?
I'll
Maybe.
send you immediately. So. Sorry for the inconvenience.
No problem.
No
Take your
problem.
time. It
No worries.
happens when with these online meetings, no problem.
I'm sending to the group. So.
Yeah. Maybe Benedetta, we can share with the participant your presentation.
Exactly.
And you say us just to when we go next. Okay. So Federica, you can share the presentation?
Yes, now we'll
Yeah,
share
thank
it.
you.
Just a moment.
Yeah.
Prova a vedere l'incontro, se no poi provi a chiedere magari segnare per ultimo. Questo non è lì, sali con l'ascensore che sta
Arrivo,
Yeah, sorry, it's my fault, so don't worry.
Arrivo. Zoom.
Since there are a lot of images, I think it's a bit heavy.
Okay.
Okay, can you see it?
Yes.
Yes.
Okay, perfect.
I'm the only one that. Oh, okay, now I can see it. Okay, perfect. So sorry again for the inconvenience, and thanks Salvo for the presentation, and thank you all to being here. Before starting my presentation, because I'm the first speaker, we decided to give you just a brief introduction about number and updates on STH. Please go. As we know, STH infection are the most common and widespread infection around the world. According to the last updated by the WHO, nearly 1.5 billion of people is affected, and they are representing almost 1/4 of the global population. As we can see in this map, there is a specific distribution because the people more affected is people living in more vulnerable and poor condition. And generally the country more affected are India, some part of Asia, sub-Saharan African country, and Latin America. To prevent, next slide, to prevent the transmission, to control the burden and the morbidity, in 2001, the delegates presented in WHA Assembly launched a resolution to try to control the disease, and this was an important public health strategy. And they decided to start the MDA, the Mass Drug Administration, and from that moment on, annually, every WHO is controlling and tracking the progresses related to MDA administration and STH infection. Also, another important document was launched in 2020, that is the Roadmap for Neglected Tropical Disease, and with document that started to track the progresses between 2020 and 2030, WHO yearly tracked the progress, and what we see in the last report is that in the last years, the treatment of STH has remained stable, but a big achievement was that in 2023, around 500 million people received the treatment for STH during the mass drug administration companies. So we have to, if we take the balance, we can say that it was a very important public health achievement. This was just to give you some updates about the number of STH. Since today we are going to see 3 different examples in endemic country. One is Mozambique. Second presentation, as Salvo will see, is about Bolivia, and then we have the example of Rwanda. So today I'm here to talk about a preliminary result of a study that we conducted in Mozambique in the rural area of Inhambane province. This study was conducted in collaboration with Medicus Mundi, that is an NGO present in the Inhambane province, in collaboration with the University of Brescia, Italy, and the University Save in Mashish, that is in Mozambique in the Inhambane province. And all the activity was supported by MISAO, that is the Mozambican Ministry of Health. So we shared the data with them and we checked the procedure. So just to give you some information about Mozambique, is a southern country in Africa with a geographic area of almost 800,000 square kilometers, with a population of 35 million people, which half live in extreme poverty. The disease prevalence is very high for the big 3. So here Mozambique has one of the highest countries for HIV, TB, and malaria. But also, if you go further, is endemic for several entities. The entities that are most endemic are onchocercosis, lymphatic filariasis, schistosomiasis, and soil-transmitted helminthiasis. The data that we have are unfortunately fragmented and outdated in Mozambique, because the survey that were conducting mainly before the country independence in 1975. That's why it's very difficult to have updated data, and this also is translated with a long-standing gaps in sustained epidemiological surveillance. What we know for survey conducted nationally and in the different region, we know that there is a big geographic variability across all the provinces, and we are seeing now. Also, to give you some other updates about the distribution of STH in different parts of Mozambique, from 2 national school survey conducted, one in 2005 and one in 2007, we know that across the country there is a high prevalence and polyparasitism of STH is frequent. But as we can see in the northern, central, and southern part of Mozambique, we have different in prevalence. The northern part of Mozambique has a heterogeneous burden. In 3 studies conducted in Cabo Delgado, Niassa, and Nampula, that are in the region in the northern part of Mozambique, the hookworm prevalence was estimated around 31%, while in Nampula, in 3 schools in a survey conducted in 2009, the global STH prevalence was around 11.6. What we know for the study conducted in central Mozambique, mainly in Beira, where most of the research were conducted, we notice a higher prevalence. For example, in a cross-sectional study conducted in 2004, the prevalence of STH was around shifted before 76% to 97% in all the ages group in which the survey was conducted, while in other study, for example, in a study conducted in a slum, always in Beira, the prevalence was higher, was 96%, and also here was frequent the polyparasitism. While the prevalence was observed lower in 2013, and this was probably due to the MDA and improved living condition, because as we can see later, MDA was introduced in Mozambique from 2005. Concerning southern Mozambique, where the Inhambane province is present, the available national data suggest also here moderate burden that can shift from 36% in Inhambane, Manisa 13%, while in Maputo is registered the lowest prevalence, around 1.5%, but maybe is underestimated. It's important to notice that all in this study, Strongyloides stercolaris was not included because it's often excluded from STH surveys. This is because it's difficult to evaluate with microbiologic technique, but we know what we know from specific study conducted on Strongyloides stercolaris. We know that the reported prevalence in Mozambique ranges from 5% to 48%. As we were saying before, mass drug administration in Mozambique, that is one of the prevalent public health strategy to control STH infection, was introduced progressively between 2005 and 2010. It was supported both by national and international partners, and the implementation started and was prioritized in highly endemic northern provinces, shifting to central and southern region. From the national document that we know from ISAO, so the Ministry of Health, by 2016-2018, the national campaigns enriched nearly all endemic districts. In 2023, around 1.4 million people received the treatment. In Inhambane, the focus of our presentation, the last MDA campaign was conducted in 2022, targeting school-age children from 5 to 15 years old, and achieving a reported coverage around 82% across the 14 districts of the province. Yes, you can go further. So the objective of our preliminary study was to evaluate the impact of MDA against soil-transmitted helminthiasis in the selected rural community of the Inhambane province, Mozambique. You see that is written also schistosomiasis, because in our study we evaluate also schistosomiasis, but because it's not the focus of today, I will skip the part on schisto. And as secondary objective, we wanted to estimate the current prevalence of soil-transmitted helminthiasis among school-age children in the selected rural communities, assess the community knowledge related to key transmission and prevention messages disseminated during the most recent MDA campaign, so the one that was conducted in 2022. The study that we conducted was an observational cross-sectional study that took part from August 2024 to September 25. We had several problems in collecting the data and conducting the activities because, as you may know, last year in Mozambique there was almost a civil war because of the election, so it was really difficult to accede to the countries and doing the study. So this is one of the limitations of the data that we have. We enrolled children aged from 5 to 15 years old attending free school in rural areas of Inhambane province. In particular, one school that is Escola Missionaria de Mocodoene in the rural area of Mocodoene in Morumbene district, and 2 schools in the rural area of Nyakivika in the Mashish district that are the cross that you can see in the Inhambane province in the map. Our study was divided in 3 phases. You can go, Fede. The first phase was the training phase and the phase of awareness activities. You can go. In particular, we had the training and awareness activity to all the research team that was composed by some people of the Brescia University, the Save University, and local technician, to the school professor, to the community leader and parents of the children, and of course to the students and to the children. The second phase of the study was the sample collection after a questionnaire administration, in which we wanted to know and to test the awareness about schistosomyces and soil-transmitted helminthiasis. So I took part in the school, explaining while the third phase was the phase of laboratory analysis. For the laboratory analysis, the sample were analyzed using the techniques recommended by WHO guidelines. All the sample were double-checked by one operator of the University of Brescia and by a local technician, and the positive cases were validated by a MISAO laboratory technician, so by a technician that works for the Ministry of Health. For the stool sample, after a macroscopic examination and the use of the Bristol scale to evaluate the consistency of the feces, we performed the direct wet mount microscopy and the concentration technique using the formolethyl acetate concentration. While, just to tell you, for the urine sample, we use macroscopic examination and concentration technique because we haven't had the filter to do the filtration technique. What we've seen in our result, we distributed to 208 kits for urine sample and stool sample, receiving back the 80% of the sample. So we enrolled in the total 224 samples for urine and for stool. Overall, the median age of the participant was 11 years old, and 54% were female. It's important to know, as you can see in the table, that only 18.3% of the population reporting being aware of the diseases under investigation, so both schistosomyces and soil-transmitted helminthiasis, and the knowledge of transmission routes was particularly limited. Only 5 children correctly identified the acquisition of schistosomiasis, while 8 the transmission of soil-transmitted helminthiasis. While more than half of the participants reported contact with fresh water. That is one of the main transmission route for schistosomiasis, while 76.6% of participants reported walking barefoot, and one fourth of the participants reported practicing open defecation for absence of latrines. So the risk behavior was quite high among our population. You can go. This is briefly about schistosomiasis. We found a low prevalence of 3.6%, but going ahead and talking about soil-transmitted helminthiasis, we also find a low prevalence of soil-transmitted helminthiasis. It was 3.1%, with a different distribution in the 2 rural areas. In Mocodoene, we found just 1 case, and Nyakivika 6, and also we found a discrepancy between the two technique that we used. Next slide. It's important to report that we detected also intestinal protozoa. The prevalence was 10.7%, and also here we had a different distribution in the two rural areas. And also here we find a discrepancy between the two techniques, the wet mount and the concentration of the stool. So what we notice and what we highlight in our study is the prevalence of STH in Inyambane is low, because even if the data are limited, we know we found a prevalence of 3.1%, and this can be translating maybe in a that Inyambane province is transitioning to a post-control or surveillance phase. Since this is the first post-MDA evaluation, we can compare with other data. But compared to the data that we see before of a prevalence estimated about 36% is definitely lower. We found a moderate prevalence of intestinal protozoa that is lower compared to other geographic area of Mozambique. And we found a difference in the two rural areas that we analyzed. This is meaning for a micro-heterogeneity of transmission. And going ahead, because maybe I'm going taking long. What we see is also a marked discrepancy between the techniques, where in our analysis, the wet mount was better to identify the fragile trophozoite like Giardia. We found most cases of Giardia with the wet mount, while the concentration with the formolethyl was better for organisms present at low density. So it's important to combine multiple microscopic methods, and if it's feasible and if available, of course, improve sensitivity with molecular approach, but not always is feasible in rural context. And also we found a gap between the awareness and the risk behavior, because what we noticed that only 18% of the population was aware of STH, but the risk behavior was high, with more than half of the population walking barefoot and practicing open defecation because of the absence of latrine. So from this part is important. MDA is a pillar in public health strategies to control the disease, but we have to integrate with education and other public health intervention like wash and water hygiene and sanitation. Our study has several limits that we know. The design of being cross-sectional, that is just a school-based sampling, and we perform only microscopy methods. And also because of the limited number of the sample, we perform only a descriptive analysis, and it was not able to perform other analysis. But this can be the start for continuing evaluating the rural area of Inyambane, also in other rural provinces, and continue to perform a post-MDA surveillance. And also combine, if it's possible, multiple diagnostic techniques in field setting. And as I said before, strengthen the integration between MDA, WASH, and health education, mostly in children. And with this, I will finish my presentation. Thanks all the research team that was present in Mozambique and coordinated also us from Italy. And thank you all for the attention.
Oh, thank you, Benedetta. Thank you very much for this very interesting presentation and for sharing these preliminary findings from Mozambique. So we now have time for just one or two questions, and I would like to invite participants to post their question in the chat or raise their hand.
We already have one question in the chat, at least.
Yeah.
Oh, yes. Thank you, Dr. Bosco. So the previous MDA for STH took place in 2022. And the previous data, we asked to the MISAO, the previous data, they were around 10%, even the only published data are around a prevalence of 36% in all the Inhambane province. So it passed 2 years, because it was in 2022, and we started conducting the analysis in 2024. And we selected 2 geographical areas. They have similar geographical characteristic, because we were analyzing also schistosomiasis. So we selected rural areas in which there was a river close by, and there were rural settings. So both to have similar characteristic to compare the analysis.
So we have another question from our president.
Any action in the region for infection control in women?
Yes, I mean, it is targeted only for school-aged children, or there are also action by the country or in the region for this class of people?
It's just for scholar-age children.
Okay, thank you.
Yeah.
I think there is also one more question from
I raised the hand. So thank you, Benedetta, for the presentation. A nice study, and I particularly appreciated the quantitative design that you also collected data about behavior, that it's very much needed in these settings. But it's not a question, but it's a remark. In my little experience, I would take these data very cautiously, because a decrease in 20 years from 30% to 3%, given this setting in which these behaviors are so spread, so open defecation, without any wash, and considering also that the last MDA was 2 years before the study, I don't know if these sample size is reliable, but a decrease of this magnitude, for me, only with MDA, I don't know if once every 6 months or once every year with, I suppose, albendazole, I wouldn't really bet on these results, that they represent the real, either the baseline was off, so the prevalence was much lower in the past. Otherwise, it would be a spectacular result, and we wouldn't have any problem in other areas.
Yeah, but thanks for the comment. I totally agree with you. That why is preliminary, because it was just like a way to start in an area in which the collaboration between healthcare center, rural area, and MISAU was never conducted before. So the idea is it was to start and give you some data also to the MISAU and say, we can find the disease, we know that they are. This is just the preliminary data that we found. We would like to extend the analysis.
Yeah, but I don't know what impact then these conclusion can be also on the stakeholders, because if you present these data to politicians and you're like, we are very near to the 2% threshold, then like they wouldn't invest more in these. I don't know. It could be like not very convenient for the program. I don't know. But I think it's a result that needs further reflection. And if you are planning to do other studies, it was a deliberate choice for the test, the choice of the test, because now you don't have any data on intensity that could be very interesting in that area. You only have like prevalence. Would you consider doing other studies, KetoCats or I don't know, FlowTac or something that can give you also a measure of the intensity? I think it really matters when it comes to MDA.
Yes, we would like to, definitely.
Yeah. Thank you.
Thank you too.
So Bosco,
thank you very much for the good presentation. And my question probably not asked well. I want to hear from Benedetta if the previous mass drug administration did it take place 2 years before? This is what you want to mean when you respond to my question?
It took place in 2022, and the previous one in Inhambane was in 2019.
Mass drug administration.
Yes.
The mass deworming.
Yeah.
Okay. Thank you. It's clear now to me.
So thank you, Benedetta, once again for your presentation and for the discussion. We now move to our second speaker, Dr. Michele Spinici. Dr. Spinici is an assistant professor in infectious disease at the University of Florence and an infection disease specialist at the infectious and tropical disease unit at Careggi University Hospital in Florence. His clinical and research activity focuses on tropical and travel medicine, with a special interest in parasitic infections and other NTDs. Since 2016, he has coordinated field activities for several cooperation and research projects on these topics in South America. Today, he will speak about the scaling down of STH mass drug administration program after 30 years successful intervention in the Bolivian Chaco. So, Michele, the floor is yours.
Thank you, Salvo, and thank you to the organizer of this interesting webinar, SOIPA and the Young Italian TB Network. I try to share my screen. Let me know if you can see my presentation. Can you see?
Yes.
Okay. So I will continue exactly from the last question by the colleague about a program that we realized in Bolivia. So we moved to Latin America. Bolivia, you know, is a country in the middle of South America without access to the sea. And the program that I tell you about is realized in this area in the southeast of the country that is called Bolivian Chaco. That is an area, semi-arid area with low density population that live in rural communities with this kind of house that maybe remember you chagas, because there are the perfect house to harbor the Trypanosoma cruzi vectors, and actually it is one of the focus, the most important focus of Chagas disease transmission in the world, the Chaco region. Then there are some urban areas with medium-sized cities, like Camiri is the biggest, the most important. It is habitated by Guarani indigenous culture population, and our history of cooperation and research of my institution, the University of Florence, in this area is very, very long, back 40 years, when for the first time my mentor, Professor Bartoloni, and colleagues started cooperated with local authorities, in particular with Father Tarcito Sciabatti, that was present in that area since mid-70s and working in health sector. He was also the health director of the region. It was and still is a region that is neglected from the central government and institution. La Paz is far away from the Chaco. and also guarani are neglected population also for health aspects, and the activities carried out by Father Tarcisio contributed to develop the health system in this area from that period, and the collaboration with University of Florence, but also with other Italian and local partners or international partners, was directed mainly to an epidemiological research to point out the needs, the health need of this region within an agreement that we have with Convegno di Salud, that is the institution funded by Tarcisio, and with the Minister of Health, of course, like as the main health authority in Bolivia. And among the most important health challenge that in mid-80s, when these activities start, were identified, of course, the SDH infection were one of the most important, as in many low and middle income countries. So one of the first studies addressed the prevalence of SPH in a population that was composed by adults and children, rural and urban, so very mixed, but the results showed a very high prevalence at the time. The red circles are for ascaris, for hookworms and trichuris, and show that at least for hookworms, the prevalence was above 50% in rural areas, but was important also for urban population. As already told before, the response recommended by WHO since a few decades to control SPH infection is based mainly on preventive chemotherapy and mass drug administration of albendazole and mebendazole. In Bolivia, it was supposed to be distributed already in 1986. It was part of the program of care for infants and mothers, and it was continued until today, but without a regular, or at least without data that can attest the regular distribution of drugs. So we try to collect data, but without success several times. But we know that every 6 months it was supposed to be distributed to children in the school-age children received from the minister, the minister program, mass drug administration of mebendazole. What we found when we checked again the prevalence of STH 25 years later, in 2011, was quite surprising, because we find that STH was almost disappeared. Prevalence very low, despite the presence of other parasites, protozoan parasites, for example, Giardia, was still at level that was comparable to that of the 80s. We repeat 2 years after this another study into rural communities to confirm the result, and we obtain more or less the same result. The STH were almost disappeared. So we, with this, take advantage from the results. We start, and according to the recommendation by WHO that recommended to modulate the frequency of mass drug administration according to the prevalence and to the change in prevalence at the reassessment of the after years of the program implementation, we start from prevalence above 50% with twice a year's mass drug administration of mebendazole. And after 25 years, we arrive at the point that was between 1 and 10%. So it was supposed to be reduced. But these kind of recommendations are mostly based on expert opinion. There's not solid evidence by the field, by empirical data that support this kind of recommendation. So we decide to start with a program of de-escalation of preventive chemotherapy distribution by a monitoring, an annual yearly monitoring of the prevalence change in selected sentinel sites. So we try to obtain empirical data from the field of what happened when in this situation, I mean, when the prevalence reduced dramatically, as we observed in this area, what happened when the drug administration was stopped at all. And we did this program in collaboration with several partners, of course, local partners, Italian partners, the University of Pisa with Professor Fabio Macchioni, and University of Roma with Professor Simona Gabrielli that contributed for the lab analysis, and also other with the supervision of international authorities like WHO and PAO. So in 2016, in sentinel sites randomly selected was suspended the distribution of mebendazole by a document issued by the SEDES, the Department Health Authority, and start this program of monitoring of the prevalence, age prevalence. These were the 9 community selected as sentinel sites. In each one, we selected 50 school-age children in the 3rd grade of primary school, and the project was included of course, a presentation and the sharing of the program with the school, with the parents, with the community, and some training and awareness activities carried out by local students to the population. And then, of course, we obtained the informed consent by parents and a demographic and some other information by a standardized questionnaire. And we deliver a box for the sample that the children give back in the afternoon. In addition to the stool sample collection, we also collect a sample of blood to analyze the hemoglobin level. That, you know, is one of the anemia is one of the most important comorbidity associated with soil-transmitted helminthiasis, especially with the hookworm. And when in the afternoon the children come back with the sample was translated to the lab where the analysis was performed by direct microscopy and cut-of-cuts technique. And then results were discussed and disseminated both with population using easy to understand way, also with local authorities and national authorities in dedicated meetings. The results show that soil-transmitted helminths where the prevalence was low at the beginning, but remained low also after the stop of preventive chemotherapy distribution. After 1 year, 2 years, 3 years, then we have to stop for 2 years due to the pandemic. But when we restart in 2022, the prevalence was still very low. And also in this case, we saw that protozoan infection, on the other hand, continue to be at a quite high level, demonstrating that circulation of oropharyngeal infection was still, and the hygienic condition in the area was not improved so much. At least one parasite was found in 80 to 60% during the years of the children that we enrolled, that were, you can see, among 350 in the last year, a bit less. Samples was more than 400 with 350 positive results, so 82% of parasites infection in the first year, to in the last year 60% of positive, at least for one parasite among the 370 samples that we collected. It is a graphic that represents the same result from the 80s to the period of our studies. You can see a dramatic reduction of SPH, while other parasites, for example, Giardia, continue to be at quite high levels, and also Immunolepis nana, for example, another Taenia, was still present without significant difference between 80s and our study. It was quite surprising also because the forecast that in 2013 were made by this model was really different from the reality. You can see that with this model that included a number of variable climatic, environmental, and socio-economic, etc., the authors forecast a prevalence of STH of about 60% in the 5 provinces of the Bolivian Chaco. That is far away from the reality that we find in the same population in school-age children. So the reality is very distant from what expected from models in this case. We try to find a explication of this dramatic decrease. The condition, living condition, the health, the hygienic condition improved from 2000 since to the start of the study in 2017, but not so much. Open defecation go down from 63% to 40% in rural areas of Bolivia. Not a real improvement that warrant this kind of reduction in STH, as demonstrated also by the presence of other protozoan infection, but also from this data, for example, that show that hepatitis A was reduced from 1987 to 2013, but not so much. 15% of children from 1 to 5 years still are encounter the virus before the 5 years, so the fecal oral infection are circulating still in this area. We also analyzed the potential impact of climate change by the change in temperature in this area from the meteor station of Camiri, but we find no difference despite the general perception was that something could be different, but in the reality, the seasonal average temperature did not change from the mid-80s to the period when we began the study. And also sorry for the Italian slide, also the mean rain and the number of days, raining days in this area did not change during this period. So it was not explication. On the other hand, we also see that another soil-transmitted element, strongyloides, reduced its prevalence from mid-80s to 2013 without specific control measures, because you know that preventive chemotherapy that, of course, had an impact on the STH reduction, but has not activity or little activity on strongyloides. So this reduction that regard specifically the young people, where prevalence dropped from 17 to 3% during this lapse of time, was also reduced. So we are not able today to say which is the main or all the cause that contributed to this observation of reduction, but we can maybe hypothesize that also the demographic characteristic of the area contributed, for example, the low density of population and other environmental factors. But what we can say is that until now, and the next year, we plan to have another point of cross-sectional study for STH prevalence, the stop of the mass drug distribution of mebendazole did not affect the prevalence. There were not increases in the prevalence that we observed. I don't know if I've ended my time. I have just a few slides to see some activities, integrated activities that we did together with the study that I show.
Yeah, 1 minute. Yeah, take 1 minute.
1 minute.
Yeah.
The first one is a WASH program, that's an intensive WASH training that we did in half schools, half sentinel sites, just to see how it impacts on the behaviors and also the prevalences. The other is by the results of the anemia, the hemoglobin levels, to see if some of these infections were associated with anemia, and we find that immunolepis nana is the only one. Of course, STH was too low to did any inference about the potential role in determining anemia, but immunolepis nana resulted associated with this condition, and it was consistent with other reports, despite it is a very neglected parasite. Then we use the same blood drop to calculate in a longitudinal cohort of school-age children that were enrolled for 3 years by this drop of blood saved in the transported in a filter paper. We perform serology for Trypanosoma cruzi, and we demonstrated that there was 4 seroconversion corresponding to an average incidence of 1.76 per 100 person years new infection. We did the same study in other areas of Bolivia, just to see if what we found in the Chaco was the same in other different ecological zones. and we found that it was not. In other areas, we found really different prevalence, patchy prevalence with higher presence of STH. And last, but maybe the most important, we integrated the analysis on stool for parasitic infection with the investigation to assess the presence of resistance determinants in the commensal bacteria of the gut. So we use the same sample to have these two important results: the monitoring of STH and the monitoring of resistance to antibiotics, gene and phenotypic resistance, and we found some concerning results, but it is another long history of our activity in the chapel. Thank you.
So thank you very much, Michele, for this very simple presentation. We only have time for one question, as we are running slightly behind schedule, and there is already one in the chat from Bosco. I'm going to read it. So thanks, dear Michele. I may have missed the methods where the same children followed up across years, or you use cross-sectional methods?
It was supposed that every year we enroll the children from the 3rd grade of primary school. So in the design, children should change every year, but in the reality, rural community were small, and sometimes we did not reach the sample size of 50 children with only the 3rd grade children. So we passed to the 4th, the 5th grade, and it happened that the same children were enrolled for 2 or 3 years. It was the reason why we can check also the longitudinal prevalence of Chagas, because some of these children without it was not an objective of the study to have the same children, but we need to include also children from higher grade. So at the end we have some children that was included in more than one cross-sectional point.
So thanks, Michele. Okay,
Salvatore, sorry.
Sì?
Compliments, Michele, and I want to just follow see you also our part of on our collaborating center, because the University of Naples is a collaborating center for diagnosis of intestinal helminthes and protozoa, and on our experience we are analyzing different data on preventive chemotherapy programs on STH control in endemic countries. And we have seen that during the last 5 years, these programs are very, very efficacy, because we have seen that we have registered this program have registered a reduction of an improvement of around 38.5% in countries. And so the combination of preventive chemotherapy and WASH and also the health education is very, very good in these endemic countries, and as also you showed in your presentation.
Thank you. Yeah.
Okay. So we now move to our third and last speaker. So Dr. John Bosco Bonigaba is a public health leader with over 15 years of experience in NTDs, program management and health system strengthening. He led Rwanda's national NTD program, reaching over 20 million people annually through mass drug administration and contributing to the WHO validated elimination of rhodesians human African trypanosomiasis as a public health problem. He is actively engaged globally with WHO and partners in policy and research, and is currently completing a PhD in public health with a focus on disease elimination and NTD. Today, he will present STH elimination journey from 2008, persisting high endemicity strategic shift and lesson learned. So, Bosco, the floor is yours.
Thank you very much, Salva, for this beautiful introduction. So, can I have the right to share? I think someone is sharing. So,
yeah, maybe Michele, can you stop your share? Yeah.
Good. Thank you very much. Sorry, can you see my screen, please?
Not yet. Yeah, now yes.
Okay, thank you very much. So, hello everyone. I'm from Rwanda. The country is a small country within the Central East Africa, and its population is around 14 million. It's densely populated, and the household size is around 4 per household. Male, females, they're almost at the same proportion. And this country is it's special in terms of hills, because it's called a country of 1,000 hills. It's made of a lot of hills. Even the city of Kigali is sitting on hills. I think Salvo saw this when he was here for his work. And here I'm just briefly talking about the journey that we went through from 2008 until now in terms of STH elimination. And the one in green color, it's mainly about the STH burden. Now the one in green is the key strategic shift. And down the arrow, we have the operational shift that we had just to adapt our system, our way of working to reach elimination. This was the goal since we initiated this STH control program. We used to have in 2005, now 20 years back, we used to have MCH week, maternal child health week. During that week, we were deworming children under 5. But we not have, let's say, nationwide prevalence data. That's why 2008, we had some partnership with the End Fund. In the time it used to be called Geneva Global. And we mapped Rwanda. And the map you see, it's almost red, mainly from rural, out of Kigali, all was red and dark yellow. This means the national prevalence was 66% at national level. Some districts could reach 90% of prevalence, others less than that. It's really high prevalence for STH here in Rwanda. And then we conduct our MDA, as you can see on here above. 6 years of MDA, we might conduct 8 MDA rounds. Why not conduct 12 MDA rounds? This is because of financial constraints. Sometimes we couldn't have money to conduct mass drug administration, and then we could skip 1 or 2 MDA. But most of the case, it was 1 MDA that was skipped. That's why we had 8 MDAs in 6 years. And when we were doing the mass the remapping, I mean, the reassessment, we now found that the prevalence reduced by 21% and reached 45%. And from there, in 2014 up to 2020, we also conducted MDA for 6 years, and there we conducted 11 MDA, close to 12. We missed only one round of MDA. What was the prevalence now in 2021? In 2020, sorry, from 2014, we had the national prevalence 39%, reduction of 6%, despite the high coverage. Normally, in Rwanda, MDA we have a high coverage. This is because we used to have a lot of worms through vomiting or expelling them. So when it comes to tablets, deworm tablets, our community are really, even men are really taking them at higher coverage. That's why we are having above 95% coverage, exceeding WHO threshold. Despite that high coverage, that consistent mass drug administration rounds in school age children in the PRESAC, we had, after 12 years, 39% of prevalence nationwide. Interestingly, this time we said, as our mission, our target was to eliminate STH by 2030 as a public health problem. We need to do not as usual. So we include the adults in our mapping, and during that time, we could see adults were higher. I mean, the prevalence was higher in adults than in school-age children. That's why afterwards, we also include adults in our MDA so that we can accelerate the progress. After these 12 years, only 14 districts out of 30 districts reached the elimination of moderate to heavy intensity for ascaris. While for tissues, it's only 28 districts out of 30. This is the achievement we made throughout these 12 years of MDA interventions. Then after this period, 2020, we did also other surveys, current central sites. Currently, we are planning to conduct the impact assessment again in the end of this year, where we'll see how long have we been in terms of reducing the intensity and the prevalence after implementing MDA in adults for now 6 years now. When you look at the shift we made at strategic level, we moved from, as you can see, from 2005, we were only under 5. 2008, we shifted to include children, school-age children. It means from 1 to 15 years old. We include all of them. Then 2021, it shifted from school children to entire community-wide MDA, just because of the data that we had. And for the operational shift that we had, so that we can ensure we have a sustainable MDA, as you see, 2008 up to 2014, we missed a lot of rounds, around 4 rounds. So it means this was because we were dependent on donor funding from 2008 up to 2018. That's why we had notification in 2018 from the donor, used to give us money for the MDA, saying we no longer support your MDA implementation. So we had to find other ways to have this MDA implemented in our communities. So we did some consultative meetings with different partners, health and non-health partners. We ended up having a good platform, already existing platform in our structures. We have school education. It's a platform that is not really modified or impacted by any donor funding. We have weekly gathering at a community level. The weekly gathering is just for socio-economic discussion at the community level, a community of around 100 households. So we said, let us use those two platforms, so that we can implement our MDA integrated within those platforms. This is what we did, and the guide was out in 2020, and it was the first MDA within this new approach was implemented in 2022. Now, with the recent cut of funding, mainly from USAID, the Maternal Child Health Week said, oh, as well as deworming was also decentralized, let's learn from them so that we can decentralize also our maternal health week interventions. This includes vitamin A administration, this includes family planning methods, this includes screening of malnutrition, a lot of intervention. This now learned from MDA, deworming decentralization integration, to now adjust to make MSH week also into routine delivery. This is what now is currently being done, and as we speak, the campaign is ongoing. So, shifting from school or children MDA to include community, general community, to have general community MDA, was it enough for us to think that everything will go well? So we said, let's conduct a trial. Let's take one area where we have high persistence of STH and conduct integrated interventions and see what comes out. This is what will be now the discussion for the next slide. It's a STH medicine trial that we had to conduct in STH persisting area. First of all, we want to check our drugs are still working, are still efficacious as used to be. So we conducted the efficacy study, and we ended up seeing albendazole was working really perfectly. Coverage, I mean, cure rate above 90% for ascaris. But as it is known for trishris, it was not really working well. But the combination, because we compared also the combination of ivermectin and albendazole, there we could see the difference for trishris, though it remained almost the same for ascaris, but for trishris, it made the difference where ivermectin albendazole is more efficacious when compared to albendazole alone, because it could reach the cure rate 70%, while albendazole alone could only go to 40 something percent, as you can see here on the figure, where it shows individual egg count from baseline to the follow-up. Follow-up was day 14. When it came, then we said, let's now take those drugs and implement them. Before even implementing, we tried to look up around other factors behind cure rate, and we could see the age, the school age state, because it's the most affected age group. It's found to be really linked to the cure rate. As you are in this age group, the likelihood of getting cured is less, is reduced to 0.29. And the other thing was the moderate intensity, as well as you have a lot of intensity of X, less chance of getting cured, which is biologically understandable. So this is what we could really identify for any STH. For ascaris, it's almost fine, except for high intensity. To get cured when you have high intensity, so it's quite difficult. The chance is 0.25 to get cured when you have high intensity for ascaris. Otherwise, when you have moderate, you can get cured. This was no statistical significance. Then we took these drugs. We said, let's implement them 3 times a year, and in other community 2 times a year. We put those drugs in the general community, and we could have those findings on the right side of the slide. Down, sorry, they might not be clearly visible. Down, you can see the egg count. In the middle, it's moderate to high intensity, while on the upper, it's just prevalence without counting moderate or any intensity of infection. So when you look at all those graphs, all those parameters that we measured, I mean egg count, moderate to high intensity of the prevalence, the 3 times a year could significantly reduce both the egg count at the end line, even in the different time points that we did, compared to the 2 times a year that we compared with. And when you look at also at the albendazole, it's clearly showing that the most impactful regime would be this combination, mainly as it works better for tertiaries. So what did we learn from the past 20 years? Is that, are you still seeing the screen?
Yes.
Okay, good. There is no evidence of reduced efficacy as when you look at the parameters of egg reduction rate, cure rate, it's really performing well. Now, despite this prolonged use or this alarming persistence of STH, still the albendazole is still working against Ascaris lumbricoides. Now, the persistence now is can be attributed to mainly rapid exposure of the population after MDA and significant environmental contamination of human feces, because in some communities they're using human feces, like this community where we conduct our study, they're using human feces as fertilizers. So the soil is really contaminated, and we know the eggs can last like more than 3 years in the soil. And imagine after deworming, you go back to farming, and you can eat something from the field because they can't take all the day without eating. Then when you eat from the field, you don't have water to wash your hands, then you get the eggs in your mouth. You are contaminated. So this is critically mainly something that we need to really address. And when you look at the other thing that we learned from previous years is that countries, despite the current years we are facing the funding cuts for mainly health programs, it was for NTD programs. We should really own our operational costs as countries, because within existing structures within the countries, exploring what's available, how can we integrate, engaging everyone, it's possible to fully own operational costs of MDAs, as we need to sustain our elimination journeys. And Rwanda planning to implement HSTH as part of the program. So with this data, they immediately uptaken the findings into policy and practice. They increased the MDA from every 6 months to every 4 months. It means every 4 months they are providing MDA. Now they scaled up albendazole combination in 3 districts now. It has been taking place last year. Currently, they are planning to have more ivermectin so that they can also provide it to other districts that are endemic for tissue. Also, Rwanda is enforcing the local Terror wash behavior change due to context-specific drivers of rapid contamination in each community, because we have seen even local small communities can have their specific drivers of STH persistence. This is because probably of the behavior using human feces fertilizers or other things. And we are still advocating for policy change when it comes to use of human fertilizers, either prohibition or regulating the use of human feces as fertilizers. Thank you very much for your kind attention, and I welcome any question for discussion. Thank you. Back to you, Sullivan.
Thank you so much, Bosco. Any question? Okay.
Oh, good that it was clear.
Yeah, everything was clear.
Maybe I have only one question, one curiosity.
Yeah.
This is just my curiosity. If you molecularly identify the species of parasites, for instance, you were talking about Ascaris lumbricoides, but we have at least another species or hybrids between Sum and lumbricoides. Did you identify at species level?
Thank you, Adriana, for the good question. at this point in time, no molecular diagnosis has been used to identify which species do we have. So we assume that we have that one, Embrycoides, but we are not sure. Unsure. No study yet done yet on that.
Okay, thank you.
Yes, I can.
Oh, okay. So thank you very much to all our speakers for their excellent presentation. And thanks again to all participants for joining us today. This session has shown how moving from control to elimination requires not only strong technical strategies, but also flexibility, long-term commitment, and the ability to learn across different settings. On behalf of the Young Italians Network for NTD group, I would also like to thank SOIPA for hosting us within this Data Parasite webinar. And so at this point, I will be very happy to hand over to Adriano or Laura for the final closing remarks. So Adriano, Laura, you want to go?
Maybe Adriano. I am in a
Okay.
faculty council, so it's better you do it. Thank you.
Yes, just to close, maybe you know that, but ironic parasitologists used to call the STH, the big one, I mean Ascaris, Trichuris, and Ankylostoma, as the holy trinity of parasites because of the impact at global level. So we end with this webinar on the holy trinity of parasites, and let's see in the next time online on other meetings. Have a good time. Bye. Ciao.
Thank you.
Thank
you all.
Thank you. Bye.
Thank
you. Bye.
Bye.
Thank you. Bye.